Okay, picture this. The ambulance doors fly open. A patient comes in, devastating injuries from some huge accident. They're bleeding out, they can barely breathe, and every single second, every second, counts. We're diving into the world of multiple trauma, and it is, without a doubt, a frantic race against time.
And this isn't some rare event. This race is one we absolutely cannot afford to lose. Because look at this. Trauma is the #1 killer for people aged 1 to 44. Let that sink in. Not cancer, not heart disease, trauma. It's a staggering fact that shows you how critical it is to get this right.
So that's the big question, right? How do medical teams take that absolute chaos, a dozen things trying to kill the patient all at once, and turn it into a life-saving system? I'll tell you right now, it's not about luck. It's all about having a rock-solid plan before that patient even hits the door.
And that plan, that system, it's literally everything. The data on this is it's crystal clear. When you have an organized, regionalized trauma system, mortality drops by a whopping 15 to 25%. Think about that. That's not about one surgeon's heroic move. It's about the incredible power of a team that knows the playbook inside and out.
So, here's the crucial part. The whole process kicks off way before the patient even arrives. The very first call that has to be made is, do we activate the full trauma team? And we're talking about a whole squad of surgeons, nurses, and specialists ready to go. That decision isn't a guess. It's based on very specific triggers that the paramedics radio in from the scene. Okay, so the first set of triggers are what we call physiologic clues. Basically, the patient's own body is screaming for help through their vital signs. We're looking at things like blood pressure tanking, their breathing rate being either super slow or crazy fast, or if they're confused or totally out of it. Those are massive red flags that the body is failing.
Next up, you've got the anatomic injuries. These are the really obvious, bad ones that you can see right away. And they are so severe that they automatically trigger the full trauma team. We're talking a penetrating injury to the core of the body, multiple major broken bones, or a crushed chest. There is zero gray area here. You see this, you call the team. And the last category is the mechanism of injury, which is really just the fancy way of asking, how did this happen? If someone was thrown from a car, or fell from over 20 feet, or was in a high-speed rollover, the amount of force their body just absorbed is insane. So the team has to work on the assumption that there are serious internal injuries, even if they can't see them yet.
All right, the patient's here, the team is ready. They immediately launch into what's called the primary survey. Think of this as a super fast, systematic hunt for whatever is going to kill this person in the next 5 minutes. It is all about speed, focus, and a non-negotiable order of operations. And this is where you really see that system in action. It's built around the mnemonic A, B, C, D, E. The team leader is literally calling it out. A for airway, is it clear? B for breathing, are they getting air in and out? C for circulation, are they bleeding out? D for disability, what's their neurological status? And E for exposure, get all their clothes off so we can see every single injury.
Now let's talk about C, circulation, because this is huge. The modern way of thinking is super aggressive. If a patient is bleeding, you don't mess around with saline. You give them blood, right away, as soon as possible. The goal is to replace what they're losing with what they're losing. And this leads us to a really fascinating and honestly kind of counterintuitive idea called permissive hypotension. You'd think you'd want to crank their blood pressure right back up to normal, right? Well, not so fast. Pushing it too high too quickly can actually be dangerous. Why? Because you might just blow a fresh blood clot right off a bleeding vessel.
Yeah, the goal is literally this simple. Don't pop the clot. The body is doing its best to plug the leak, so the team's job is to help it out, not get in the way. They'll let the blood pressure ride a little low, just high enough to keep the important stuff like the brain and kidneys happy, until a surgeon can get in there and fix the leak for good. But, and this is a massive but, there is one scenario where this entire strategy goes right out the window. A head injury. You do not mess around with the brain's blood supply. The brain is super sensitive to low pressure, so if there's even a hint of a brain injury, permissive hypotension is off the table. Full stop. We get that blood pressure up.
Okay, so let's say the biggest fires are out. The immediate life threats from the primary survey are managed. Now the team can, take half a second to breathe and move on to the secondary survey. This is where the real detective work begins. It's a slow, methodical, head-to-toe search for all the things that might have been missed in that initial chaos.
And trust me, things always get missed at first. A nasty cut on the scalp can be hidden by hair and bleed a shocking amount. A broken arm doesn't seem like a big deal when you're dealing with a collapsed lung. And you're never going to see an injury on the patient's back unless the whole team works together to carefully roll them over. This second pass is all about making sure nothing gets forgotten.
All right, now we're getting into what is probably the single most dramatic procedure in all of emergency medicine, the ED thoracotomy. This is the crack-the-chest move you see on TV. And let me be clear, this is the definition of a last resort. We're talking about a procedure for patients who are actively dying or are already gone.
The goals here are brutally simple and direct. 1. Get that chest open and relieve any pressure that's squeezing the heart. 2. Find the hole and literally plug it with your finger. 3. You can clamp the aorta, which shunts all the remaining blood up to the brain and heart. And 4. You can actually do open cardiac massage. It is the ultimate Hail Mary.
Now, because this is so extreme, the reasons to actually do it are incredibly specific. I mean, razor thin. For penetrating trauma, like a stab wound, you'd only consider it if the patient came in with signs of life, and then their heart stopped in the ER. For blunt trauma, the window is even tinier. They had to have signs of life when they arrived, and you've been doing CPR for less than 10 minutes.
And this decision isn't just some gut call made in the heat of the moment. As you can see here, it follows a super strict algorithm. It's a flowchart. Were there signs of life? Yes or no? How long has CPR been going? It's all designed to find that 1 in a million patient who might actually have a chance, and to avoid putting everyone through something that has no hope of working.
So when you look at all of this, the team activation, the ABCs, the complex procedures, what do you think is the most important tool in the entire trauma bay? Is it the scalpel, the high-tech ventilator? What is it? It's the system itself. That's the tool. It's a calm, well-rehearsed, step-by-step process that everybody in that room knows by heart. It's the framework that lets a group of people stare into absolute chaos and create order. It's how they beat the clock, and how they give that patient the absolute best shot they've got.